need to run and I don't do this not on your own. Memories fade, but you stay the same. Never saying what you know.
The sheer math of climate change has become so overwhelming that everyone recognizes that we need to do this.
This is going to be a really pivotal year.
Carbon capture,
Wind and solar.
Electrified vehicles.
Sunshine in my life. Rain keeps pouring down. The night is getting colder. I'll keep waiting it out until the summer's over. 'Cause I got this feeling we're gonna make it. 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 I need a little sunshine, baby. Don't want no maybe. I'm missing you tonight. You know you got me going crazy. A love so hazy. This ain't no paradise. I need a little sunshine, sunshine, sunshine in my life. I need a little sunshine, sunshine, sunshine in my life. Yeah, come on.
This is just the beginning.
Welcome to the first virtual event of our Vitals Checkup series, where we'll unpack the most consequential topics shaping healthcare today. I'm Tina Reed, healthcare editor at Axios. I'm coming to you from Washington, D.C., and I'm excited to join you all on the Axios stage for the first time. Thank you to United Health Group for making this conversation on disparities in maternal health possible. Welcome to our audiences on Facebook, Twitter, LinkedIn, YouTube, and on Axios.com. You can join the conversation today on Twitter with @Axios and #AxiosEvents. Over the next 30 minutes, I will be joined by my colleague, Sarah Kehaulani Gu, where we will unpack the systemic racism and historic foundations of this crisis, its impact on mothers today, and how policymakers and practitioners are addressing these challenges. Our first guest is the Illinois Congresswoman and co-founder and co-chair of the Black Maternal Health Caucus, Representative Lauren Underwood, who is joining us from Naperville, Illinois. Welcome, Congresswoman.
Thank you, Tina. I'm really glad to be with you.
Well, I'd like to start by framing this problem of maternal mortality in the United States. Could you describe some of the disparities that we're seeing right now and what we know or don't know about what's causing this problem?
Yes. So in the United States today, Black birthing people are 3 to 4 times more likely to die from pregnancy-related complications than their white counterparts. And for every death, there are 70 near misses. So we have this dual crisis of maternal mortality and morbidity. And this disparity that we're seeing among African-American birthing people and to an extent as well, Indigenous birthing people, that's what's driving the United States' overall high maternal mortality rate. In fact, it's the highest in the developed world. And we've seen this high level of maternal deaths my entire lifetime, and I'm 34 years old. These maternal deaths are caused by many issues. In my state of Illinois, the leading cause of maternal death is substance use, overdose, and suicide.
Can you talk a little bit more specifically about what role systemic racism is playing in this problem?
Absolutely. So, I'm a nurse, and when I was in nursing school, they would tell us about this maternal mortality disparity and say, there's just something about Black women. And it's like, no, there's nothing wrong with Black women. This is it's a healthcare system that has systemic racism in its foundation. And so what we are trying to solve is a problem where Black birthing people are not heard, they're not listened to, and there's these barriers in place on getting equal care and the best healthcare possible for the moms and the babies. And so that's really what this is about. I think that, some people are a little bit uncomfortable with this idea of a healthcare system displaying systemic racism in the way that ours does. However, there's no denying the fact that it's just really one group of people that continues to die. And this is a disparity that exists regardless of income or education. It doesn't matter where you live. It doesn't matter your insurance status. It doesn't matter whether you got prenatal care, right? You can control for any of these factors. And still the disparity persists, right? There's no denying that racism is a key component.
Can you talk about your personal connection to this issue and how it got you interested in this topic?
Yes, when I was in graduate school, I had a great friend. Her name was Dr. Shalon Irving. She was as committed to ending health disparities as I was. And in January of 2017, when I was wrapping up my service in the Obama administration, she was preparing to give birth to her first child, a beautiful baby girl named Soleil. And then 3 weeks later, we lost her. Now, Shalon had a dual doctorate. She was a lieutenant commander in the United States Public Health Service Commission Corps. She was an epidemiologist at the CDC. She had done everything right, and we still lost her at 36 years old. And what had been just theoretical or something that I learned in a classroom was all of a sudden very personal to me. And that spring, as I was making the decision to run for Congress, I knew that if I won my election, this would be an issue that I'd want to take on in the House. And so that's why I'm so proud of the work that we've done as the Black Maternal Health Caucus and the development of our Momnibus legislation.
Let's talk a little bit about that legislation. You reintroduced that legislation, a package of 12 bills now earlier this spring. Can you talk about what it does and who it's trying to help?
So the Black Maternal Health Omnibus Act of 2020 is a comprehensive suite of 12 bills to address every dimension of the maternal mortality crisis in our country. Now, we were not aiming to be duplicative. And so you won't see, for example, the Medicaid expansion in the Omnibus, right? So many of my colleagues, led by Robin Kelly, has really been leading on that effort. We were trying to fill in the gaps. So what our Omnibus addresses are things like social determinants of health, growing and diversifying the perinatal workforce, addressing digital tools like telehealth, and also the COVID pandemic, right? Recognizing that birthing people, whether they're pregnant, lactating, or postpartum, hadn't been included in clinical trials. And so as a result, we've not seen the same level of robust vaccination recommendations. We've not seen information about treatments, right? And we know that there's also been kind of longstanding gaps in maternal vaccination public outreach. And so we actually have two bills to address that issue. Late last summer, there was some data that was published in JAMA talking about the linkages between climate change, right? Extreme heat and air pollution, maternal and infant health outcomes, right? So that's now in the Omnibus. We are really addressing every dimension, both clinical and non-clinical factors that are impacting maternal mortality and severe morbidity. And really pleased to be able to do it in this bipartisan way. We have 3 bills in the Omnibus that have bipartisan support: our legislation addressing women veterans, our legislation addressing mental health and substance use, and our legislation dealing with telehealth.
I'd like to move to one of our questions from the audience. They wanted to know what aspects of the Omnibus Act, if passed, will adjust the high C-section rate for Medicaid births.
So that is not something that we're addressing here. This is explicitly around maternal mortality. And so I think that because we have that kind of very narrow, specific focus, it allows us to be successful.
And can you talk a little bit more about the perinatal workforce? What's the focus there? And I guess what is the issue we've seen there?
So we recognize that in so many communities across the country, whether it's urban or rural, many birthing people don't have a choice in providers, right? They don't have the option to select a provider that shares their race or cultural background, that speaks their language, or maybe has a shared religious point of view. And we believe that we need to not only grow and diversify that workforce, but also that we need more obstetricians, we need more physician assistants, more midwives and nurse midwives, we need more doulas and lactation consultants, right? We want birthing people to have a choice and have that not be restricted because of geography. And so we know the data has been very clear that when you have some of those congruences and the choices among providers, the birthing outcomes are better.
Can you also talk about the piece of the bill that actually calls for extended Medicaid coverage for new mothers?
That is not in the Omnibus. That's what I'm saying. So the Omnibus is, yeah.
Okay. My apologies. I'd like to dig a little deeper on what's happened over the past year. How has COVID-19 really changed this conversation around maternal mortality?
COVID-19 has really shined a bright spotlight on longstanding health disparities in this country. Maternal mortality is one of those, right? There's been data that has been so clear, published in the MMWR, the CDC's Morbidity and Mortality Weekly Report, that shows that when pregnant people get COVID, they're more likely to have severe COVID illness, and they're more likely to have negative maternal health outcomes, and Black and Hispanic birthing people are more likely to be diagnosed to begin with, right? And so we're seeing this racial disparity and also just this really dangerous intersection between COVID and pregnancy. This was on top of a spring of 2020 when birthing people were asked to deliver their children in a hospital without family support, right? And so in a healthcare system that's already, diminishing the voices of some birthing people and not hearing complaints around pain or around something being wrong, then you don't have that support structure with you, right? The level of anxiety was so high. And so that is why it's so important for us to have these two bills in the Omnibus, the Maternal Health Pandemic Response Act, which I introduced with Elizabeth Warren, and the Maternal Vaccination Act, which Terry Sewell has led for us in the House.
What do you think the chances are of this legislative package gaining traction and ultimately passing? And what hurdles stand in your way?
We are so excited. This week has been a fantastic week. We have so much momentum. So we're up to 140 co-sponsors in the House and in the Senate. Shout out to our Senate sponsor, Cory Booker, who has been an incredible partner with us. We have had so much support from leadership, from Speaker Pelosi tweeting out support of the Momnibus, to Leader Hoyer being a founding member of our Black Maternal Health Caucus, to Chairman Takano marking up the Protecting Moms Who Served Act in the House Veterans Affairs Committee earlier this week, to Chairwoman Maloney holding a hearing around maternal health and the longstanding disparities today before the House Oversight Committee. There is incredible momentum to solve this problem. President Biden and Vice President Harris share our point of view around making this a priority, and they've carved out some space in the American Families Plan for this legislation.
And finally, what are some other legislative priorities of the Black Maternal Health Caucus?
We are very engaged around the postpartum Medicaid expansion, which would extend coverage from 60 days to the full year postpartum. We're so pleased that that was included in the American Rescue Plan. Illinois became the first state to take advantage of this new pathway. It's very exciting. And we're looking to make this a permanent change. So the Helping Moms Act is going to be coming back. We are also focused on the appropriations process and making sure that we are devoting resources to great resources in the states, like the perinatal quality collaboratives, for example, that can be tools for local and state leaders to really address the impact of this crisis that they're seeing in their communities.
Well, great. Well, thank you so much, Representative Underwood, for joining Axios today.
Thank you.
And next, we have a View from the Top segment with my colleague, Vice President of Comms at Axios, Yolanda Brignoni.
Thank you, Tina. Now joining us from Shepherdtown, West Virginia, Chief Medical Officer for Maternal Child Health at Optum Population Health Services, Dr. Janice Huckabee. Hi, Dr. Huckabee.
Hi, Yolanda. How are you?
I'm good. How are you? Thank you so much for joining us today.
Thank you.
Well, let's start off. Healthcare, of course, has been a big issue for a lot of us this year. What can you share about what United Health Group and Population Services are currently focused on?
Well, it's sort of a twofold experiment at present. One is continuing to serve members who are struggling through the COVID pandemic. And the other is, at the same time, maintaining our focus on improving maternal child health, which has been a challenge during the pandemic. Some of the learnings from the pandemic, I think, will help us as we do the second job. And that is, we've learned the importance of telehealth. We've learned to think outside the box. And I think that kind of perspective is important for us as we consider how we can improve outcomes for birthing people in this country. You know, as you know, Yolanda, 700 women a year die of complications related to childbirth. And because United Health Care, our benefits business, provides coverage for about 1 out of 10 of those babies born, this is an issue that is very near and dear to us. So we've been doing several things to try to improve outcomes, even as we've battled COVID. One is we've done extensive search through our data to find those areas where we might have the most impact, areas where the outcomes tend to be worse than others. And we've met with hospitals and given community grants to educate women about the signs and symptoms of complications and to help them find their voice to speak about these kind of things. We're also partnering with a couple of large medical groups to do remote patient monitoring around high blood pressure, which is one of the leading causes of complications in pregnancy. We're doing some work with intimate partner violence with a health system in North Carolina, because in some states, the medical reasons for maternal mortality may be related to pregnancy, but homicide is often a close second. And we've also wanted to empower the clinicians and case managers who may be employed by United Health Group through Optum to make sure that they're meeting people in a culturally sensitive and appropriate way. So we've had training that we've partnered with the CDC and Morehouse School of Medicine around implicit bias, especially as it relates to improving maternal outcomes.
Great. Well, let's dig in a little bit, particularly when it comes to racial bias. Maternal mortality is especially a big issue for Black women. Black women of no matter what their socioeconomic level tend to have poorer outcomes when it comes to maternal health than other groups of women. What else are you doing to kind of respond to that?
You know, we've partnered with organizations such as the Joint Commission, which accredits hospitals, to incorporate the patient safety bundles that were developed by the Alliance to Improve Maternal Health. And with our support, now all hospitals, when they get their accreditation, are going to have safety measures in place that are taken from those bundles around hypertension and hemorrhage, which are two of the main causes of poor outcomes. Now, that's obviously going to impact all women, not just communities of color, but still, it was a way that we were able to assist. To further focus on those vulnerable communities that have done poorly, we've invested in community organizations such as Any Baby Can, that actually goes into the homes and meets people where they are to help improve outcomes. Another group that we're working with is called Cradle Cincinnati, which develops Queens villages that have served as a strong peer support group and really helped improve outcomes in Cincinnati, Ohio. And with our support, they're going to expand throughout Ohio and a couple of other cities outside the state as well. We're also looking to how we can support through our physician practices that Optum owns with, as I said, the remote patient monitoring, which is largely in those vulnerable communities as well. So there's some other things, but those are ones that come to mind as you ask.
Wow, that sounds great. One of the other learnings of this year has been COVID, of course, and that added sort of an extra layer of complexity on an already kind of complicated system. And some would argue that has exacerbated even the inequities that are already in the system when it comes to maternal health care. What are you at United Health Group doing, and what are you urging policymakers to really do to sort of fix some of the problems that are appearing?
Well, you're exactly right. I mean, I think COVID, not only in the way the disease impacted, but now some of the challenges we've seen around vaccinations have further demonstrated the disparities. And there's a part of me that's like, yes, see, we weren't making this up about maternal health. There really is a systemic issue. We do know that even as we look at things like virtual health through devices, that we have to make sure that communities aren't left behind. And we have supported in some instances devices being furnished to people so that they can do remote visits and those type of things. When it comes to policy, we support coverage for all people in the country, and especially would support the extension of prenatal benefits to women for up to a year after they've given birth. The reason for that is some of the complications don't manifest themselves right away. And we think that if women can have additional health care during that period, we'll probably see a decrease in the number of unplanned pregnancies, but also see women maximize their health before they embark on another pregnancy. We also think that continuing to spotlight and prioritize women's health is important. 30 years ago, we did a lot of great work to decrease the neonatal mortality rate, and we need to give that same focus now to the moms.
All right. Well, I thank you so much for your time today, Dr. Huckabee. Really appreciate it.
Thank you so much, Yolanda. Have a great day.
You too. And now over to my colleague, Sarah Gu.
Thanks, Yolanda. I'm Sarah K. Helani-Gu. I'm the executive editor at Axios. And now for our final guest, I have with me the CEO and president of the March of Dimes, Stacey D. Stewart. She's joining us from Washington, D.C. And welcome, Stacey.
Thanks, Sarah. Great to be with you.
Well, let's dive right in. I think most people are familiar with the March of Dimes for its history and important work on behalf of the healthcare of children and babies, particularly the history of polio. And now, decades later, you guys have shifted your attention to the focus of women, particularly pregnant women and women who are having children and their healthcare. We know that the rate of women who are dying after childbirth, particularly women of color, has really gone way up, and we're last now in the nation compared with developing countries. Why have you and your organization decided to pivot to this issue now?
Well, first of all, thank you for having me. And you're right. A lot of people know the March of Dimes from our history with polio, but for March of Dimes, we would not have accomplished getting a polio vaccine, some decades ago. But we were able to lead the effort on that. Obviously, President Roosevelt founded the March of Dimes. So it's really an amazing organization. And once polio really got solved, and of course it would be solved everywhere around the world, but for access issues. But once it got addressed here in the US, we turned our attention to other issues. So we moved to looking at other issues affecting children, birth defects, and other issues like that. A lot of folks know if you're pregnant taking folic acid, you know that because of the March of Dimes. If your newborn baby got screened for a number of different healthcare outcomes at the time of birth, that's because of the March of Dimes. But then we turned our attention to other large issues impacting newborn babies. And the biggest issues that a lot of people don't really think about is the issue, or even know about, is the issue of premature birth. Babies that are born too sick or too soon before 37 weeks of pregnancy. And premature birth and the consequences of premature birth are some of the leading causes of death for children between the ages of 0 and 5. It affects about 400,000 babies almost in the US, 15 million around the world. It's a major issue. But your point is well taken, because when we look at the issue of premature birth, it's really important to understand that having healthy babies has to be tied to making sure that the moms that are delivering those babies are healthy too. And what we find is that the health outcomes for moms is really not what it should be in this country, as well as the health outcomes for babies. And so we look at the March of Dimes at both issues together. The issue of maternal health and infant health, looking at preventable maternal mortality and morbidity, looking at preventable preterm birth and infant mortality, and then especially looking at the health equity gaps across both of those areas. Making sure we have healthy babies is making sure we have healthy moms, and we have to make sure that every mom and every baby is healthy, irrespective of race, ethnicity, or the zip code in which her family lives.
You raised such an important point, I think, in talking about both sides of this, the babies and the mothers. And it's so fascinating to me because you think about where technology and healthcare has come a long way for babies in particular. Anybody, for example, who's had twins or knows someone who's had twins, multiple births are much more common today, knows it's amazing. My sister had twins, for example, and we know that there's technology and care available to enable a baby as little as like 2 pounds to have a very good chance at a healthy outcome, a healthy life as a child and an adult. But I wonder if you think the healthcare industry or the healthcare universe has perhaps taken its eye off the ball for the mothers, perhaps.
Well, you're exactly right. I mean, we certainly have made a lot of advances through technology in helping babies survive and thrive in the neonatal intensive care unit. Sometimes babies even less than 2 pounds are able to survive and really go on to live full lives. But here's the issue. Premature birth, babies that are born that sick and too soon, even if they survive and are able to move on through life, after they leave the NICU, often face lifelong health challenges. Premature babies often face lifelong health challenges like developmental delays, cognitive delays. They suffer from cerebral palsy, a range of different challenges. And sometimes even the babies that seem to do well and thrive through childhood may, if they were born prematurely, have health issues down the road as adults. So just the fact that we're able to help babies survive and thrive is very good in the neonatal intensive care unit. But we can't lose sight of the fact that being born prematurely as opposed to a full-term birth is simply not ideal for most babies. And the other issue that you mentioned is around the moms. Have we taken our eye off the ball of women and moms? There's no question about that. We haven't actually provided adequate health care for all moms and all women before pregnancy and during pregnancy for a very long time. We have a number of moms who still are not able to access high quality prenatal care. We have many women who suffer from chronic health challenges and they may be uninsured, so they can't manage before pregnancy, so they can't manage their health before pregnancy. And those chronic health conditions can actually threaten their lives during pregnancy and threaten the lives of their babies. We have a lot of challenges with respect to having taken our eye off the ball of women and our health, but also making sure that we're doing what we can do and doing more to protect the health of women when they become pregnant so that they're healthy and that their babies are healthy as well.
I want to ask you on that point about a report that your organization put out last year as called Nowhere to Go, Maternity Care Deserts across the United States. Can you share with us, where did you find, geographically speaking, these maternity care deserts were? And what's driving it? Why is there such a lack of care in some pockets of the country?
Well, we did this study first in 2018 and then updated it in 2020 to look at this issue of maternity care deserts. A lot of people know food deserts, right? Places where you live where you may not have access to nutritious food. Well, there are, in fact, maternity care deserts. There are counties in this country where there is little to no access to obstetric care. No access in a county to a hospital that offers obstetric services, to an OBGYN, to even one certified nurse midwife, or no birthing center. About 54% or so of the counties in this country are either considered fully maternity care deserts, no access to that kind of care, or may have very limited access. So maybe one of those may exist in the county, but not a full array of obstetric services. And the issue with this is that women who live in these maternity care deserts may have limited access, even if they have insurance, remember, they may have limited access to care because they cannot easily get to prenatal visits. They cannot easily deliver, which is especially risky if they are a high-risk pregnancy trying to get to a hospital that may be not so nearby. They may have to travel 50, 60 miles just to get to the nearest healthcare provider. About 4/5 of all of these counties are in rural areas, but about 1/5 of them are in urban areas. We live in the Washington, D.C. area. We would consider, for example, Wards 7 and 8 to be almost a maternity care desert. It is very limited access to care. And women may have to travel, 30 minutes, 45 minutes, maybe up to an hour, maybe on public transportation just to get to a prenatal visit, may have limited access to being able to deliver, especially if they have a premature birth. It may be really putting at risk their health or the baby's health just because they live in areas where access is so little. So there's so much we have to do to correct the systemic failures in our healthcare system. But the last thing I want to say about this is that we know that health and wellness is determined mostly by how we live. Certainly it's important to have healthcare providers and have a clinic or a doctor that may be nearby. But when women live in areas where there is a lack of good nutrition, when we live in areas that housing is substandard, when we are not paid for our work at a fair level, when we experience too much stress and anxiety, as is true for many, many women of color especially, that can impact our health. And those are the systemic challenges and failures we really have to address, in addition to those failures in the healthcare system per se.
Well, thank you, Stacey. As you point out, this problem is complex, and it has many solutions that will hopefully get at some of this. Thank you so much for joining us and for sharing your expertise on this really important topic today. We appreciate it.
Thank you so much.
Thank you so much for joining us this afternoon for another virtual conversation with Axios. I want to thank our sponsor, United Health Group, for making this conversation possible. And I want to thank you, our audience, for being part of it. For more healthcare coverage, I strongly recommend you join and be part of our Axios Vitals newsletter. You can sign up for free at axios.com/newsletters, and you can join our coverage and follow along on axios.com. Thanks again and have a great afternoon.